Thank you, Renee. There we go. All righty. I'll be moving slides today, and I'm going to ask Q to help me present. I didn't tell her ahead of time, so this will be a bit of a surprise to her. I'm just kidding, Q, I'll do it.
I was like, we'll just go. We'll go with it.
I haven't seen you in a while, so I had to just say hello that way, I guess. Okay, folks, so we have a big initiative going on, as many of you know, and it's really kind of changing how we think about things, and we have a lot of, anticipation, and maybe it's the best word, for what's going to happen and how it might affect us, and trying to understand and wrap our arms around all that's included in it. I am going to do a fairly quick overview of what's included in this so that we have time for our ECHO presentation. But as you can see here, what we have is a summary of all the kids initiatives that are going on, and very probably not all the kids initiatives, right? There's so many of them. But some of the major ones are related to a whole system of care transformation. We've got the Family First Initiative, which is going on through JFS. We have Children's Services Transformation. We have Crisis Continuum for children, adults, and adolescents. We have our MSY, Multi-System Youth Initiatives, Modernize Ohio, FCFCs. We have OhioRISE. We have Behavioral Health Workforce. And this is just a summary of some, because we have so many, right? One of the things that I want to say here, I mean, it's because incorporated into all of these is other initiatives like cultural competency, resilience promotion, trauma-informed care. What's not mentioned on here is youth and family peer support. There's a whole lot going on in Ohio, folks. I didn't call out early childhood here. So it's the most exciting time that I have been in my career doing children's mental health. So I'm very excited. I'm very excited that it's a system of care focus. And I'm excited that each of the state departments are working together to help make this happen and agreeing upon it. So I promised I'd talk about the core services that are going to be either new or taken statewide in a bigger way. So FFPSA, which is the Family First Initiative, the first tier of services that are getting implemented are multi-systemic therapy, functional family therapy, Ohio Start, Healthy Families America, and Parents as Teachers. Healthy Families America and Parents as Teachers are our home visiting models for early childhood. Our Ohio Start is our own model for that is implemented through child welfare and PCSAO. And it's the only one of these five that's not considered evidence-based. So the rest of these were listed on, the chosen evidence-based models that you could pick from. And every state picks a different set. And this is the set that Ohio chose. So 50% of the services that get delivered have to be evidence-based. And because we have such a major penetration and development already of Ohio Start, that's probably going to take about 50% of the other stuff, right? And keep in mind, this is for kids that have open cases in a child welfare agency, okay? So Ohio Start, Healthy Families America, Parents as Teachers probably will get utilized the most. Having said that, we're hoping that multisystemic therapy and functional family therapy are also utilized for those kiddos that are 11 to 17 and a half, who have externalizing disorders, who may be at risk of involvement with the juvenile justice system, and also are involved in the child welfare system. So it's a bit complicated, but these are the services that are going to get offered through Family First. And there will be additional supports made available to agencies wanting to implement those services. I thought I would take a second and talk about the difference between MST and FFT. And as you can see in the side-by-side, the biggest difference is really about intensity. Multisystemic therapy utilizes what we consider to be an intensive home-based service delivery model with small caseloads, 4 to 6 at a time, with intensity of provision of the service, multiple weekly sessions, and they're on call 24/7 to the families they serve. Some of the difference here is that FFT, the caseloads, as you can see, are higher. The service can be delivered both in the office and the home. They average about 1 to 2 hours per week, one session, and it's what Renee and I would consider to be, and Mike, pure family therapy, right? Where they're sitting with the entire family and they're working on systemic dynamics and those things on a weekly basis. MST also has a family therapy approach, but they work through the parent or the caretaker to affect change in the family. I'm looking at Renee as I'm talking because I want to make sure I'm saying it right. Okay, good. Thank you. And FFT is not on call to their family. So there's a slight difference in the implementation and the intensity of these two services, but they both serve a similar population of kiddos that are at risk of involvement in the juvenile justice system. Here's where we have or are creating or developing MST and FFT in Ohio currently. So I wanted to show you a quick map of that. If it's dark green, that's where we have MST alone, and currently being implemented. If it's kind of that darker tan, that would be where FFT is being implemented currently. And then the other colors, the kind of, oh, heck, I'm lousy with colors. I don't know. The light yellow greenish thingy that, I don't know, is where we have pending MST creation. And anybody who can help me with the right color, please let me know. And then the purple would be where FFT teams are pending. And then this light blue is where both are considered to be delivered at that time. So we're getting there. But as you can see, the penetration of MST and FFT statewide is still not there.
Looks like a lime and then an olive green and maybe a marigold.
Thank you, Q. See, I knew you were going to help me in my presentation today.
It was only right.
Okay, thank you. Thank you. And I will try to remember that for the future. So what are our OhioRISE services? Well, obviously you're going to hear a whole lot of intensive care coordination. Intensive home-based treatment is in there. MST and FFT fall underneath IHBT, so they're in there as well. You'll hear something about psychiatric residential treatment facilities being offered. Certainly our new service, MRSS, which the Department of Mental Health and Addiction Service has rolled out over the last 4 years, the Engage 2.0 grant. And then some services through the 1915C waiver, which I don't have time to get into today. I did want to offer this kind of overview, the broad stroke overview of what I think a complete system of care should offer youth and families. Certainly, we always talked about what services should be there, but there needs to be a complete continuum of services for youth and families across the age of development of those kids as well and families. We need a planning process to help organize and to develop new services that might be needed or new interventions that might be needed, unique to that youth and family need. and that would be our high fidelity wraparound, our service coordination, and child and family teaming, depending, it's named different things depending on the system that implements it. Ohio Star calls it child family teaming. It also needs to have supports, peer supports, mentors, respite, etc. These things are so necessary for families to be successful, and you need policies to support all of the above. This is why I'm really excited about OhioRISE, FFPSA, other state initiatives, including the Governor's Children initiatives. They're all supporting this direction where we have a planning process, support, services, and policy, all supporting system of care development for kiddos. The OhioRISE core services, multisystemic therapy, functional family therapy, but also, as a part of that is intensive home-based treatment and the full array of those, and there's more statewideness with that. MRSS, and then our intensive care coordination and moderate care coordination. This is for your reference because I want to make sure I get through everything. But what I wanted to do in this slide is just kind of differentiate between how MRSS, IHBT, and high fidelity wraparound are similar and yet different. The major difference is, MRSS is a very brief 4 to 6 week involvement. It's a quick touch. It's a stabilization service and linkage. And it can be delivered by licensed behavioral health professionals, but also QMHS or QBHS, as well as peer support. I need to fix that in the slide. And they're on call 24/7. They don't have an identified caseload because they have to be ready to serve any number of families in any given week. IHBT is a treatment service that does individual counseling and family counseling on top of everything else, but it's a comprehensive service that also includes crisis intervention, safety planning, much like MRSS, and much like high fidelity wraparound, right? And these are services that are on call 24/7 as well. Small caseloads, 4 to 6. It's defined. Length of stay is anywhere from 3 to 6 months, and they're intensive services delivered multiple times each week to the family. And then your high fidelity wraparound is not a treatment service per se, it's a planning process, right? And I can't emphasize that enough. It's a way of planning for what the family needs to be successful. Caseloads of 12 to 15, and a length of stay is about 12 to 18 months on that. Yikes. Some more on intensive home base. This is where IHBT is located in Ohio right now. And we are creating a new tier, which will include licensed and unlicensed teaming, which we think will expand IHBT statewide. So we're excited about that. And that's what this slide talks about. In terms of MRSS, the major definition of the service is basically there's got to be crisis availability 24/7, 365. There will be a uniform triaging process that will go through a centralized call system, probably through the 988 system that's getting developed. One of the core principles is that the family defines the crisis and we respond, okay? That initial response is always mobile with a few exceptions. And it needs to be mobile to that crisis, wherever it's occurring, whether it's at the family's home, community, neighborhood, school, within 60 minutes, followed by a 72-hour kind of, stabilization, safety planning phase. And then that's followed by, 4 weeks or so of ongoing stabilization and linkage to ongoing services. This is where MRSS exists in our state currently. It's about 8 programs serving about 15 counties. That's pretty good considering it's just been piloted through 2 system of care grants, right? But we're about to take this statewide, which will be a fairly major lift. And there will be a lot involved with that. Along with all of these things, all the rules have been revised, right? So to stay up on this, you can always go to the OhioRISE website and find out what the most current rules are. There's new rate setting that's going on as well. There will be a new meeting on that next week or the week after. So a lot going on. In terms of high fidelity wraparound, you guys on the call on the Echo today, this is something that you're most experienced in through our local FCFCs, but it's a team-based planning process that's needs rather than service driven. And the core thing is that youth and families have equal voice and choice and are partners in the planning process. And high fidelity wraparound is a way of leveling the playing field. We'll have these new services, ICC and MCC. We don't have time to really get into anything except to say that the difference is that intensive care coordination, the care coordinator to youth ratio is 1:10, and for moderate care, it's 1:25. And then limited care coordination will happen through Aetna. And I didn't see a caseload size for that yet. But these other two services will be implemented through a very brand new thing called a care management entity, and the RFP for that will be coming out shortly through Aetna. The other thing that's an integral part of OhioRISE and all of these initiatives is the CANS decision support model. And the CANS will be used for care planning, for eligibility, for level of care decision-making, and to communicate between whoever's involved working with the family, as well as helping the family do planning as well. There will be a brief and comprehensive CANS. More to come on that. If you go into the PowerPoint, I've summarized the domains in the brief CANS, as well as the comprehensive CANS. There's about 55 items in Ohio Brief and about 83 in the comprehensive. And if the kid's over 18, there's 91. And as you can see, all the state departments are utilizing the CANS for eligibility, for care planning. And this is just a chart that summarizes all of that. In terms of certification and training, there will be ongoing training between now and January and even ongoing. The Parade Foundation will handle the first leg of training, and look for more to come on this. They haven't put out their official training schedule yet, but we're hoping to see that in the next week or two. If you're currently certified in the CANS, you can go ahead and do the CANS. You just need to do a booster 2.5-hour session with the Parade Foundation. That'll be made available soon. You're grandfathered in, but when you recertify, you've got to take the Ohio CANS certification. And if you're not currently certified, then you have to sit through 2 3.5-hour sessions of the Parade Foundation training and then going online to get certified. We'll offer additional coaching. We want you to pass. And this is how we're prioritizing who gets trained when. So it's just really based on which initiative is getting implemented first. So QRTP, Title IV-E stuff, that's first, along with DOD's staff for the ICF increased rate. So those are the folks that are prioritized at the beginning, and then the CME and the MRSS folks will be next. Damn, I just went through 34 slides in less than 15 minutes. Thank you very much.